Hello everyone. In this video, we are going to discuss how you should approach congenital adrenal insufficiency or congenital adrenal hyperplasia questions. So if the adrenal gland is not producing the hormones that it's supposed to, it will undergo hyperplasia as a response. Now, the questions are often like this, where a newborn in this question is born to a 30-year-old woman, and we can notice that the blood pressure is very high. Infant's blood pressure is 145 over 90. Then there is clitoromegaly and fusion of the labioscrotal folds. So this we can see is virilization. And what will be the hormone responsible for virilization? It will be androgens like testosterone. So we know that androgens are elevated for this patient. Then laboratory study shows sodium of 150 and potassium of 3.0. So sodium of 150, normal sodium range would be somewhere between 136 to 146. So this is on the higher side. So sodium is elevated, serum sodium is elevated. And what about potassium? We can see that the potassium is 3.0. So normally it should be between 3.5 to 4.5. And here it is 3, so it is on the lower side. We are dealing with hypokalemia. Now we have to know which of these enzymes, if they are deficient, would lead to this picture. And a very easy framework that I keep for this is we begin with cholesterol. And then you have to think that if 17 alpha hydroxylase acts on this cholesterol, it's going to push it to androgens and it is going to push it to form the glucocorticoids like cortisol. And in order for cholesterol to form aldo and cortisol, which are your mineralo and glucocorticoids respectively, you have to use two enzymes, 21 hydroxylase and 11 beta hydroxylase. So for both the mineralocorticoids and glucocorticoids, 21 hydroxylase and 11 beta hydroxylase, to go down this pathway, these two enzymes are very, very crucial. So to build this framework, you can very easily draw it. Start with cholesterol and just remember the order 17, 21, 11. And then the deeper we go, the sweeter it gets. So we start with mineralocorticoids like aldo, glucocorticoids like cortisol comes next, and then finally androgens, from which all sections of the adrenal cortex they are being produced: zona glomerulosa, zona fasciculata, and zona reticularis. Right? Now let's take this framework and apply it to our question. So coming back to our question, how do we approach it? Now, if a patient does not have 17 alpha hydroxylase, what will happen? We will not get, please follow the purple lines, we will not get glucocorticoids like cortisol and will not get androgens, which means that the whole cholesterol will be pushed to form mineralocorticoids like aldosterone. So the aldo level is going to get elevated, of course. Then if aldo is getting very high, we know that the blood pressure, aldo retains sodium and water, it will elevate the blood pressure. And aldo, once the RAS system is getting activated and aldosterone comes into picture, it thrashes the potassium. So the potassium is going to be low. Then we know that the purple stuff is not happening, right? 17 alpha hydroxylase is not there. So we're not getting cortisol and androgens. So there will be less cortisol, less androgens. And of course, when you don't have androgens, there is going to be, in case of a male, ambiguous genitalia and undescended testis will be described in the question. And for a female, they'll lack secondary sexual development. In this question, this is not the scenario we're dealing with. But in case you have a patient with 17 alpha hydroxylase deficiency, you'll find that their blood pressure is high, their potassium is low, their androgens are low, which leads to ambiguous genitalia in males and lack of secondary sexual development in female. If you just keep this framework in mind, you don't have to memorize any of this. You can easily deduce it just like we did. Now, what about 21 hydroxylase? This is the most commonly tested and it is actually the most common congenital adrenal hyperplasia because of 21 hydroxylase is most common. Now, if you don't have 21 hydroxylase, this part is not happening. So the whole cycle is going to be pushed along the 17 alpha hydroxylase to form androgens. So you're going to get lots of androgens in case of 21 hydroxylase. What about cortisol? So in order to go down, in order to go from cholesterol, you required 17 alpha hydroxylase, which was there. But again, to reach cortisol, you required this essential 21 hydroxylase, which is not there. So cortisol will be low. Similarly, your aldo and mineralocorticoids are going to be low. Now, if aldo is not there, what will happen to potassium? There is nothing to trash the potassium. So the potassium levels are going to increase. And what about blood pressure? There is no aldo, there is no cortisol. The blood pressure is going to be low. So in this scenario, in case of a male, there will be virilization because of so much androgens. In case of a female, there will be virilization because of so much androgens. And in case of a male, there is going to be precocious puberty. So they'll get puberty faster, right? So we are dealing with precocious puberty in this case. And there could be salt wasting. There will be salt wasting. Why? Because what causes retention of salt and water? Aldosterone causes retention of salt and water. Now, if aldo is not there, by feedback, the renin activity is going to increase. This is something you should keep in mind. Now, coming to the last one, 11 beta hydroxylase deficiency. 11 beta hydroxylase, if it is not there, this enzyme, if it is not there, again there is problem going down the mineralocorticoid as well as the glucocorticoid pathway while you get lots and lots of androgens. So there is no doubt that the androgens are going to be high. But there is one very important thing. If you don't have 11 beta hydroxylase, we still get something called 11 deoxycortisterone due to the action of 21 hydroxylase. 21 hydroxylase is there, so you get 11 deoxycorticosterone. Now it is because of this 11 deoxycortisterone, which is somewhat like a mineralocorticoid, it is like aldosterone. So it exerts the effects of aldosterone. So you can imagine in this situation, 11 deoxycortisterone is actually going to increase a lot. And that is going to, because it has activity of the mineralocorticoid, the blood pressure is going to increase. So your blood pressure is going to increase, and similar to other mineralocorticoids, 11 deoxycortisone, it is going to thrash the potassium. Potassium is going to be low. And what about your cortisol? Cortisol is going to be low in this case. Cortisol is going to be low. What about aldosterone? What about your aldosterone? Aldosterone is also going to be low. What is high? There will be low aldo, but there will be high deoxycortisone. Deoxycorticosterone. This is a very important point, and this is responsible. This 11 deoxycortisterone activity is actually responsible for elevating your blood pressure and lowering the potassium level. And again, because the androgens are so high, the females are going to be virilized, the males will undergo precocious puberty. But because you have this mineralocorticoid activity going on, your mineralocorticoid activity is preserved, the renin activation will not be there. By feedback, renin activation will not happen here. Now look at this question again. Blood pressure of the patient is high. She's undergoing virilization. So we can see here that the androgens are high. Potassium is low. Sodium is actually high. Sodium is being retained. So we are dealing with a case of 11 beta hydroxylase. So when there is 11 beta hydroxylase deficiency, what happens? In this situation, your androgens are going to actually increase a lot, and your 11 deoxycortisterone is responsible for elevating the blood pressure, whereas because 11 deoxycortisone has this mineralocorticoid like activity, blood pressure is high, potassium is low, and sodium is actually being retained, so sodium is high. And the correct answer here will be 11 beta hydroxylase. So this is all about congenital adrenal hyperplasia, and just by, if you can draw this simple schematic, you'll be able to arrive at the correct answer. So thank you so much for tuning in today. And if you're interested in more such content, please make sure to subscribe to our channel, and please like and subscribe. Thank you so much for tuning in with us today. I hope you found this session extremely useful and now have a much better understanding and confidence to tackle this topic. If you're looking for more in-depth guidance and tips, please check out our website, thematchguy.com. It's a platform dedicated to helping med students and also medical graduates. We simplify complex concepts, distill the content for you, and provide personalized support. We are all about supporting and helping you achieve your dream match. So if you're preparing for USMLE or your residency applications, you're in the right place. Thank you so much once again, and until next time, keep working hard, keep learning.